The following Hospice Foundation of America program originally was produced for healthcare providers' clinical education. This shortened version is provided by HFA to help individuals with dementia and their caregivers. Hello, and welcome to The Longest Loss, Alzheimer's disease and dementia. I'm Frank Sesno. The latest figures available for this program show dementia is the top non-cancer primary diagnosis for hospice admission. According to the Alzheimer's Association, the number of people living with the most common form of dementia may triple in the next 2 decades. Neither the healthcare system in general nor Medicare's hospice benefit in particular was designed to deal with a lengthy disease process during which cognitive decline often far outpaces physical debility. And just as troubling, the person with dementia and everyone around them is trying to cope with numerous losses over an extended period of time before death with little practical or emotional support. I'm joined now by our panelists, Chuck Core, Professor Emeritus, former chair of the International Workgroup on Death, Dying, and Bereavement, and currently a caregiver to a loved one. Nancy Pierce, a licensed social worker and author of Inside Alzheimer's, How to Hear and Honor Connections with a Person Who Has Dementia. Kathy Supiano, Associate Professor, Researcher, Practicing Clinical Social Worker, and Psychotherapist. Peter Rabins, also a Professor Emeritus, Founding Director of the Division of Geriatric Psychiatry and Neuropsychiatry at Johns Hopkins and co-author of The 36-Hour Day. And Ken Doka, Professor of Gerontology, Licensed Mental Health Counselor, Ordained Lutheran Minister, and Senior Consultant to Hospice Foundation of America. And welcome to you all.
Thank you.
Thank you. Ken, especially good to see you here for the 22nd time. Well, welcome, as I said, to all of you who are joining us for this fascinating conversation. Just like the body, the brain can show wear and tear too. Who among us hasn't had one of those senior moments when a fact or a name eludes us, or we've forgotten about an appointment, or where we put the car keys? It's normal for that to happen as we age, they tell us, but not long ago, people having more senior moments than lucid ones were said to be senile. Today we say they have dementia. There are 4 major types of dementia. The most common is from Alzheimer's disease, which is predominantly a memory disorder. So that's usually the first symptom that arises, and it is the overwhelming feature of the disease. Lewy body dementia has Parkinson-like features, like slowness, stiffness, gait or balance problems, visual hallucinations, spontaneous changes in alertness and attention, and a sleep disturbance where people act out their dreams. Vascular dementia typically comes following a number of small strokes, although it can occur after a large stroke as well. The most common feature of vascular dementia is a change in someone's ability to solve problems. In frontal temporal degeneration, the predominant symptom in some people is a change in personality and behavior. In others, it's a language change, where they either have trouble making words or trouble with word comprehension. Regardless of its type or cause, though, dementia, as we said, is not a normal part of aging in and of itself. Peter, is it?
No, that's correct, Frank.
And why and what is the distinction?
Well, as you said, we all sometimes have trouble coming up with a name or a word. But in dementias of all sorts, the normal functioning level that a person's had is not being not met. So the person's no longer able to do things that they've always done easily throughout life. It's a big change.
And at what point does a person or a loved one say, this just doesn't feel like normal memory loss to me, let's go get this looked at?
It can be a challenge at the beginning. Often it's when somebody starts repeating themselves more than just occasionally, or not remembering something important. We all forget appointments and that sort of things, but if somebody's getting married in a coming up weekend or some other important events coming and the person forgets that, that's probably a reason to be concerned.
But not necessarily one of these dementias, or probably, or let's just go look?
Well, you should always look. It doesn't necessarily mean it's dementia. It could be medication the person's taking. It could be a depression. It could be some other physical disease like thyroid disease. So there are many causes of these symptoms, but I think it's important to have a physician assess a person and try to determine which of the possible causes is it.
Okay, great. That's our jumping off point. So through the years, several illnesses acquired social stigma. AIDS, leprosy, and bipolar disorder are examples. Some would say dementia is too, as depicted in the movie Still Alice.
What's going on?
Oh boy.
He's gonna break up, or?
No. I have Alzheimer's disease. Early onset.
Oh my God.
But we have to keep the important things in our life going.
Merry Christmas.
We have to try, or we're going to go crazy.
This might be the last year that I'm myself.
Please don't say that.
Julianne Moore won an Academy Award for her role as the title character, a linguistics professor at Columbia University in New York. In Chicago, Mary Moreno was a strong, independent, and confident woman. But for her son, Cesario, accepting Mary's illness was as difficult as watching her decline.
Even though I saw changes in her, I always thought that that it'll stop, it'll slow down, it will something, it'll go away. And so because of that, I think, also being so close to my mom, I think we don't always see those things. We don't want to see them. It takes other people to point out what's really happening. And even when you hear them, I made many excuses for her. Oh, come on, she's 77 years old, cut her some slack. Or, you start being defensive because you don't want to hear that we're losing her. Nobody wants to hear that.
Nancy, nobody wants to hear that. Does delaying or shielding the diagnosis affect the grieving process?
For a lot of families, that's a necessary part of the process, is to delay the acceptance of that. The other part that makes it very difficult for families is that other people are saying, what are you wrong? Look at her. She doesn't know that that's a cup of water. And so much of the family's desire is to prove mom is okay or dad's okay. And so there's often that head-to-head conflict, I think, with people around. This is a bigger-than-life diagnosis for a lot of us.
It's calamitous for a lot of us.
It's totally calamitous. And mom or dad has it, and does that mean I'm going to get it, is the next logical step for people to go to.
Ken Doka, when does the grieving process or the grieving begin then, Ken, in this
Right
spectrum?
at the very beginning.
Right at the very beginning.
Yeah, and it begins on a multiplicity of levels. It begins for the person who's experiencing the disease and beginning to recognize, things aren't quite right. And it certainly begins for the family, and it continues throughout that whole process.
Chuck, you bring a phenomenal perspective to this conversation, both because of your expertise and, as we indicated in the introductions, your own status as a caregiver for your wife. Your thoughts then on the grieving process, being an expert on that, as well as being a caregiver for someone on dementia, and what that spectrum maybe looks like for yourself or for others?
Well, it's interesting to think about the kinds of losses you have. For Donna, we took in a stray cat about 9 years ago, and he recently developed healthcare problems that couldn't be dealt with, and he had to be euthanized. That's a major loss for her right now. She talks about him all the time. He was a wonderful kitty, and she wonders if she could get another. So not all the losses are directly related to the disease. They could be somewhere else, and I think that's particularly useful for healthcare providers to think about, because they may see the person right here and may not realize that last month this happened, or my brother died, or whatever the other loss might be.
Peter.
Yeah, I think to build on that, Chuck, one of the challenges here is that for the person with the disease, they're very much living in the present, but they're losing the past and the future. Whereas we, as family members and professionals, have the past and the future and the present. So it's harder for us sometimes to put ourselves in the shoes of this person, because we can't imagine, how could she not know that Ken visited us yesterday? Or sometimes, how could she not know that her mother died?
Ken, is this spectrum of grief, because of the peculiarities of this disease as we've discussed, acknowledged?
Sometimes we don't really understand the scope of losses that one really has. Number one, as a caregiver even, because your own freedom is now constrained. Going out to the store now is not just a spontaneous activity. It has to be planned. Going on a trip has to be planned. Who's going to take care of the person? Who's going to watch? Are they going to take care of it as much as? So you lose a sense of independence. You lose a sense of your assumptive world. This is not the retirement years that I envisioned. I envisioned us, skiing up in the mountains and vacationing, not taking care of this person. So there's a lot of, you lose friends, and not because friends necessarily close the door on you, but just because your life becomes consumed, you're not going in the normal activities. Life changes dramatically in caregiving. And then I think the other thing is you have a sense of psychosocial loss. And what I define that is that the persona of the person is so different that, even though the person's alive, it's not the person you knew.
Nancy, is it possible to connect with somebody with fairly advanced dementia at the end of life?
Very possible from my experience. And I think the hard part is that we tend to discount the person eventually because we kind of don't know how to make that connection anymore. Yet when I have, or other people that I know have gone in and spent time with that individual, it's amazing the shift that can occur.
So tell us what you would do when you walk in the room, you see this person.
Yeah. First I'll go near them, and say, "Hi, Mrs. Gilbert. I know you don't look the part today, but play with me here." "Hello, Mrs. Gilbert. I'm Nancy. I'm here to visit with you. Do you mind if I hold your arm?" And I will do it within visual contact, within visual range of the individual. It never ceases to amaze me that there are some people who will go like this.
Lean toward you.
Leaning away from me. There are some people who do it. Vast majority like it. The vast majority will even lead toward it or reach toward me.
And if they lean away from you?
I don't touch them.
Peter?
Many people lose the ability to understand language. They have what we call an aphasia, but they still understand the tone of your voice, the caring,
Cadence,
and that's why the touch is so important. So the cadence and the warmth that you express, they respond to that, but they don't really respond to the words. And you have to learn that that's the disease. It's not a choice. True. It's the fact that you're speaking with them in a way that somehow is caring, and I can't describe it more than that many people appreciate. And you can see them warm up to it. You can see the color return to their face. You can see people smile, even at the very, very end of the disease, when people are barely able to move. Stroke a person's cheek, and boom, the person comes out.
Kathy, I want to talk to you about something, because the person toward the end of life may not be completely incapacitated either. And I just had a very dear friend who just lost his mother. And the situation was this. She was pretty cogent and reasonably communicative up till about 2 months before she died. But she was thoroughly disoriented.
Right.
And she wanted to be home. And what this friend of mine told me was, for the longest time he'd say, "You're not at home, Mom. We're not home. You're not." And then he realized and learned that, and as he described it, I had to go there with her.
Exactly.
Can you talk about
Yeah,
that?
and I think this is just so therapeutically important in every situation, but particularly with dementia, we start where people are at that moment. We join them where they are. And objective truth doesn't matter. This is not the time to say to someone, "Your home is in Ohio and now you're living with me in Florida." I mean, that's not a fact that's going to happen.
And what if they see in you, you're suddenly not, my daughter, you're now my sister?
This happened in my own family, Frank, where as my grandmother progressed in her dementia, she could no longer recognize her daughter as her daughter, but recognized me as her daughter because I looked like my mother did 20 years earlier. And again, just to be able to go with that and join with people, and right and wrong, truth doesn't matter here, but just respecting that person's reality and responding to the feelings, whether they're fearful, whether they're agitated, whether they're loving, just responding to the feelings, so much more important than the facts.
One of the things that Donna says right now when we go out to lunch, she likes to go out to lunch, and when we leave a restaurant, she will say, "Did I leave my purse? Have I forgotten it?" And our nurse daughter, who's a geriatric nurse practitioner, says, "Dad, it's not about logic, it's about reassurance."
Reassurance.
Which is a good thing, I think, for caregivers to think about. And you can reassure in lots of ways. You can say, "Don't worry, Donna, Chuck took care of that." Or, "Your purse is at home and that's where we're going." Or, "No one stole it." There are a lot of ways that brighter people than me would be able to reassure someone like my wife.
For Kathy Stack in St. Paul, Minnesota, caring for her beloved Tom became increasingly difficult. Despite numerous health issues, Tom was relatively fine for a while, but then he began to wander in their apartment building, could no longer do simple transactions with his credit card. And as Tom became increasingly dependent, Kathy became more aware of her own losses.
It was like it became my full-time job. You know, I was really fortunate in that I was able to take an early retirement because all my time and energy went into advocating for him, navigating the healthcare system, hiring, firing doctors, you know, that type of thing. So it was just a really huge adjustment. But I think coupled with that sense of pulling back from the things that were important to me was the fact that he didn't have a whole lot of insight. He wasn't very appreciative. He said I was a control freak and I was always telling him what to do. And I think he was really struggling to adjust for a very, very long time. And we would have sharp exchanges and he would say things that I don't think he really meant, like, if this is too much for you, why don't you just move out? Or things like that. It was painful because we were a couple for 17 years. By the end, it wasn't a very warm, loving relationship anymore. It was more duty, responsibility, you know, that type of thing.
Tom died in 2007 while in hospice care, and a postscript to this story is that Kathy, who now you just heard, now knows that she too has Alzheimer's disease. And she told us she's considering moving to the same facility where Tom spent his final days, perhaps starting out in assisted living, then moving into the memory care unit when the time comes where she could also receive hospice service. Kathy, I want you to think about the other Kathy. You were just, and you were nodding your head throughout.
Think of her multiple losses, the loss of that relationship with any other illness in a relationship. You can talk about it, you can process it together, and now the very person you might have gone to for comfort is much less participatory in that relationship. Just think of that loss too. The loss of freedom, the loss of independence, the constrained life that she lives, the sense that the relationship transforms now to duty. We hear this so very frequently. And we really do have to commend caregivers who go the distance.
Chuck, can advanced care planning have an effect on the grief experiences of either the patient or the caregiver?
Oh yeah, and I think that's one of the things you'd certainly want to recommend to family members and to care providers who can help family members with that. Anything you can say that we've arranged that, we've talked about that, we know how those decisions, we've either made those decisions or we know how they would be made. We would turn, for example, to our nurse daughter, who's a wonderful teacher and very experienced in this area. So yes, I think the more you can plan ahead and adjust a plan rather than just say I've got a plan fixed and it's never going to change. The more you can plan ahead, the better off you are when things get more difficult.
How does that affect the grief experience?
Well, what I do when I work with family caregivers is I do what I call, relatively early on, the line in the sand. Because I think there's part of the nature of the disease that where you say, well, let's just take it one day at a time. Let's not really plan ahead. Let's not really think about that. And what I usually do is I usually say, okay, when will this become too tough for you? When will you have to consider another alternative? And usually people say, well, when he becomes incontinent, or when this happens, or when that happens, or when he starts wandering, or she starts wandering. And what's interesting is, in my experience, most people go way beyond that line before they decide to shift to assisted living or a nursing home. Now, this reflects back on the grief, because I think when people have done that advanced planning, and as I said, usually go beyond what they thought they were capable of, they look back and they say, I drew the line here and I went here and I feel good about that. And I think when they don't do that, sometimes they get to that point and said, I promised him I never would put him in a nursing home. I had to do that, and that complicates grief.
I have what I call the 3-strike rule that I tell people. If
So we
you
have the
try-
line in the sand and the three strikes.
If you've tried something 3 times and it hasn't worked, it's very likely that it's the dementia, whether it's taking someone to a concert or having them get dressed. You try it, it's not your failure, then you go on and deal with it in a different way. There's another loss, I think, that Kathy touched on that I'd like to bring up, because I think for people watching, it's sometimes helpful to point that out to the care provider, and that is you lose the give and take of a normal relationship. So, you know, we all get frustrated with our partners and family members.
Never.
Well, you're special. You're special. But some of us do anyways. And, you know, you lose that ability when someone gets a little frustrated or angry and say, well, why don't you just leave or whatever. You can't work that out.
Yeah. And
the way you
that
normally
was
do.
so difficult in
You
the
know,
city.
and we can, so number one, pointing out that that's a loss itself of the relationship. And number two, then sometimes instructing people, what can you say in that circumstance that lets the conversation keep going? That can be very helpful for the professional.
And I think there's just one other loss that I'd like to underline too that I saw in that little vignette, and that's sometimes you lose a sense of who the person was, and you start questioning, did we ever have this good marriage? Or, you know, I knew one daughter who came to counseling, and her mother had been this very progressive, she had been a Southern woman who had made great sacrifices in the civil rights movement, you know, to fight for equal rights for African Americans. And then in dementia, she started using racist language and making racist comments. And to this daughter, that was a devastating loss. Who was this woman?
Kathy, I want to ask you, if you would, to define for us complicated grief and whether there are predictors of post-death complicated grief that are distinctive in dementia caregivers.
Well, I think, first of all, we all agree that there's no such thing as simple grief, instantly solved grief. But complicated grief is that form of grief that's actually disabling, that the griever is not able to resume any sort of normal life now that they cannot reconcile or come to terms with this death. So better not a time frame or anything like that. But in the setting of dementia, one of the things that's a risk factor is a sense of not doing enough as a caregiver, which is just so ironic. People caregiving for 10 years, and then when the death happens, they doubt themselves or they feel guilty. And they often sort of paralyze themselves by feeling relief afterwards.
Well, we heard Kathy Stack's truth, her description of the toll dementia caregiving took on her relationship and her lifestyle. So let's hear now from Joyce Simons. She's in Rockland County, New York. She learned of her own dementia in 2007.
I'm really having a difficult time just remembering what day it is. And I have to focus. But that's something I did not, you know, I guess when you see the progression, and that's not a big deal, but I noticed that's something that I can't do that I was able to do before. I pray. I keep busy. I go a lot. In my, you know, professional life, I used to be on boards and I used to go places and I had things to do, and I attempt to do that now. I deal with the loss by not thinking about it and forcing myself to do things, to go to plays and have people, you know, do things with my organizations and going out. But the more I am out, I don't think about it. That's how I really deal with it. I don't think about the fact that I've lost my old self and my new self is different, a little bit more fragile, but it's different nonetheless.
Chuck, Joyce strikes me as an amazing woman and remarkably self-aware and articulate even now. Is she grieving?
Yeah, I think it would be helpful to make a distinction between grieving and whatever other term you want to use, mourning or coping, or most grief, when we think of grief, I think we think of the reactions to whatever's happened to us. But most of us go further than that, and we begin to think about responses. How am I coping? So this lady is choosing to pray, for example. Most of us try to find ways of coping, and depending on how you use your language, is that grieving or is that mourning? All those words are those little ing words, they're participial words, and they're all about activity. They're all about doing something, which is another ing word.
And they're present tense.
Yes, and they're present tense, that's right. Yes.
The present tense.
And again, she's not denying, she's just choosing not to dwell on it. So this is actually a very effective way of coping, and ones that family members do as well. Yes, they're aware, yes, they think about it, but they'll use some distraction, they'll use something else to return them to a place that's more pleasant.
Nancy, Joyce was almost eloquent in places, but think about people with much more advanced dementia. Do they have the capacity to grieve, and if so, how?
Oh, that's a big question. Yes, I feel they do. I have seen the grieving occur. I've seen even the grieving occur in individuals that theoretically aren't tuning into anything in the environment.
Really?
In the form of they're normally a very passive individual, and then all of a sudden very tense, very agitated, no ability to calm them down except in the moment and touching them. But the second you leave, they get agitated again.
Yeah, and I think sometimes in the, certainly in the early stages, like we saw here, grief is, your understanding, your ability to enunciate your losses is very accessible. You can say, yeah, this is a loss. I'm not my old self. I'm not sure if I like my new self. But I think later in the disease, there's often just a case of a feeling, for lack of a better word, a sense of unwellness, a sense of, that something's wrong, something's off kilter. You know it, you may not be able to put your finger on it, you may not be able to identify it, but you know that the world is not the way it's supposed to be.
So what factors influence anticipatory grief when it comes to dementia?
Well, anticipatory grief is an interesting word, and I always like what Therese Rando says, that it's a misnomer, but useful nonetheless. and what she means by that is when we think of anticipatory grief, we think, okay, I know this person's going to die, and so therefore I'm anticipating their death and grieving, in anticipation that this person who's been an important part of my life is no longer going to be. What Therese Rando reminds us of is that's just a very, very small part of the grieving process. That in reality, this grieving or this mourning, as Chuck would say, and Terry Rando would say as well, is really about all the losses you're experiencing in the course of the illness. And those losses are multiplied, and sometimes they're very complicated, particularly with dependent, with very ambivalent relationships. And again, you talk about dementia. Dementia brings those into fore. It brings a certain ambivalence about the life and death. It brings dependence.
Peter, I wonder to that point what you advise family members or caregivers when they have had a more complicated relationship, and they're now having to rationalize the complicated relationship with this diagnosis, with end of life. None of this is what anyone would have thought was scripted for them not very long before.
Part of the loss is that you can never now fix it. There is always a chance that maybe you could have made up. But now, because of this disease, that chance has been taken away from you.
So does that further complicate the grief?
It does, but again, I think by bringing it out in the open and talking about it, it doesn't have to be an impediment.
Yeah.
So it's okay to wish you could have fixed it up and realize that that's an opportunity in a sense lost, but what can you do now to relate to your mother the way she is now and help the person in a sense move on to that?
And I think we'd all love to hear your perspective on what Nancy was sharing earlier about this notion of people with advanced dementia being part of this conversation or being able to grieve themselves. What's your experience?
Maybe I'm like Chuck. I'm not sure we have to use words like grief and mourning. If somebody is very upset or distressed, I think we have to realize they are experiencing fear or fright. And relating to that emotion, maybe commenting, you seem scared. And they may tell you something that has absolutely nothing to do with what's going on, but they are talking about their feelings, and I think it's helping people have even very advanced dementia, being able to say, I'm scared, I'm frightened.
What if they can't say those words?
Sometimes I'll say, you look frightened, and they may agree or they may disagree, they may shake their head, they may not understand it, and again, I think then I might be reassuring. I think sometimes one of the things I think that the tape illustrated before was to stop somebody from having that conversation is really a mistake. You know, to say, oh, look, your memory's not that bad, you're doing okay earlier in the disease. But even late in the disease, it's okay for people to be angry and frightened.
Or cry.
No, cry. If they're suspicious and paranoid, realize that's what they're experiencing. And of course, the truth again doesn't matter. We can't say, Mom, I would never steal your money.
But the truth does matter if at that point in the disease, actions are taking place. You've got to deal with them. You may have to seek legal authority to make decisions for your loved one. Kathy, I'm interested
But you don't have to build that on the back of the patient. So yes, you have to put protections in place, and yes, we have to take care of people who may be unwilling or uncooperative in care, and we do more of that by cajoling than strong-arming people. It's just so much more effective. What the challenge about this is not that there aren't ways to do it, but it's really hard for caregivers not to take that personally. You know, if you're a loving and faithful son and your mother in mid to late stage dementia says, Frank, you've stolen my money, it is very hard, even if you understand the disease, not to take that personally and feel wounded by that. And so as clinicians, we can navigate people through that. We can reassure people that you're doing the right thing, it must be distressing, and just as I'm available to your mother, I will be available to you to help you navigate this.
Very interesting. I want to do a slight turn and look at dementia here from a slightly different perspective. In Plymouth, Massachusetts, Ann Burnham welcomed her mother-in-law, Carol, when it became clear she could no longer safely live alone. But after a short time, Ann and her husband realized Carol required more care and supervision than they could provide in their home.
We took her to the assisted living and interviewed and had her walk around the place, which was an absolute gorgeous place. And so we moved her in and made her comfortable. And, you know, 2 weeks later, we were talking and she said, I can't believe you just dropped me off here. And she had no recollection. So she became very withdrawn and didn't want to go to the meals, didn't want to do any of the activities. And so she was there for about 1.5 years. And then we moved to the South Shore. And so we moved her so she would be nearest to assisted living here. And that place that was beautiful, that she hated, she cried all the way 1.5 hours ride down here because we were taking her away from her friends there, although she hadn't made any friends, but it was, you know, moving. So she came down here and she did reasonably well in the beginning, but then she had some medical issues and she went downhill pretty rapidly. And so we moved her into a secured area for people with various dementias. And she was there for another 1.5 years before she got really bad. And then we moved her into a nursing home. And with every transition that you do with someone who has Alzheimer's, it really throws them off. It really sets them off, and it's just, it's difficult to see because I think it speeds up their decline, but sometimes for financial reasons or for medical reasons or for personal reasons, you have to move them.
Ann says that to this day, she and her husband struggle with guilt over moving Carol out of their home, and even though their decision was made to keep Carol safe, Ann says they can't help but feel that they abandoned her. So, Kathy, these are some of the wrenching decisions that people face.
And just the sense of failure, when what's driving this is disease progression, not the failure of caregiving. And but just each one of these steps, a necessary transition, difficult transition to more supported care, feels like a failure to this family.
Kathy, is there research about grief outcomes for people who move patients, parents, others, or into nursing homes?
It's really not clear on that. I think for some people, the move is the upheaval. For other people, it's the increasing care challenges in the home, even if the person ages in place. So much of this is how we construct the meaning of these changes, not necessarily the changes itself. But I think the uniform piece here is perceiving that need for change, however, as driven by failure rather than this is the disease. Interestingly, we don't do that as much with other disease forms like cancer and so forth. Each necessary next support is not a failure.
You know, in this circumstance, again, I think it's important to acknowledge with the person with dementia, yes, it's hard to move, and we agree with you. We wish it didn't have to happen, Mom. We still love you. Then you turn to the feelings. Okay, we love you. That's what's important, and we know it's hard. You've given up all you. Again, maybe it's not true. All the friends you'd made, now you've got to make new friends. That's hard. That was hard for me when I was in kindergarten. Allowing people to talk about feelings, I think that's much more important than saying, oh, it's the transition, or it's not moving, or the fact that you did it too late. You can't change those things even if they are true. But
and the bridge in those places is relationships, which is relationship trumps geography every time.
Peter.
I think we all recognize that people die from dementia. Right. But in fact, many families, many people working in long-term care, many physicians, social workers, and nurses don't know that you can die from dementia. And I think one of the things that we all can do is educate the public that it's a fatal disease. It causes people to develop pneumonia. It causes people to stop eating. It causes people to fall and break their hip and die. And I think as society appreciates you die from progressive dementia, we will be able to then recognize people need these services like hospice earlier in the course of the illness.
Hold it. Let's come back to it because I do want to switch gears here now. And the federal government has an innovative program for veterans with a variety of illnesses, including dementia, who want to avoid institutions, even though remaining at home or with family is not an option. The VA's medical foster home program works just as it sounds, matching veterans with sufficient resources to civilians who receive training, compensation, and ongoing support as foster caregivers. In West Orange, New Jersey, Ethel Gordon has 3 fosters in her home, including a World War II veteran with dementia.
George is 94 years old, and every day I get up looking forward to meet George that day. Whatever George he produces, I look forward to it. When I get into the program, I knew George's age. When I interviewed George, I smiled from the time I saw him to the time the interview was over, because he was so strong and full of confidence. It's as though George don't know his age, and he just does everything George wants to do. So me now, I know George is not here with us for a long time, and that was one of my biggest challenges. And I think I already braced myself that George would leave us one day. To tell you the truth, when I interview him, I give him 5 years. In my mind, I would not tell him that. And I brace myself for whatever situation it is. I just tell myself every day he live, I would make sure he enjoy every minute of the day.
Wonderful.
Although Ethel knew from the beginning that George could pass at almost any moment, family caregivers typically prepare for the long haul, expecting dementia to progress over many years. But sometimes nature throws them a curve, and the person with dementia declines much more rapidly or dies much sooner than expected from some other causes, like a heart attack. So Ken, let me turn to you. How can that circumstance ultimately affect the grieving?
Often people die suddenly today in the midst of chronic illness. And what we mean by that is that you know they're going to die, and you know they have multiple, but you know many elderly people, they don't just come with dementia. They have high blood pressure, they have diabetes, they have a whole series of diseases that and conditions that you're trying to keep in some kind of stability. So it's not unusual that all of a sudden that'll happen, and you knew they were going to die, but you didn't expect they were going to die then. And then you have to really deal with some of the components of, a sudden death, which can be complicating, and others may not recognize and acknowledge that families can perceive that as sudden, because here this person was ill, they had multiple illnesses, but you didn't expect that person to die when they died. So that's that can become a potentially complicating factor.
Peter, this goes with the territory.
Absolutely, and anticipating the fact that, again, people may feel even guilty about that. Oh, then we could have prevented that heart attack,
Yeah.
and I should have done something else. And
is that common?
Absolutely. Yeah. And we put so much emphasis on life and living that death is often a surprise to the person and the loss who's experiencing that loss. Whereas to everybody outside, well, this person's been declining for years. I'm not surprised he died. But to that person, it is an acute loss.
Earlier in the program, Kathy Stack spoke about the challenges of caring for someone with dementia. About a year before we conducted that interview, Kathy had learned that she too has the disease. And we heard Joyce Simon speak of her own dementia, which was diagnosed in 2007. In both cases, people around them sometimes still don't realize or refuse to believe that they're ill. In settings like hospices, nursing homes, adult daycare, and even in popular culture, someone with dementia looks and speaks very differently than Kathy or Joyce. So let's watch Dr. Sunny Kanowski of Fisher's Alzheimer's disease program at NYU Langone Medical Center with Mary on a home visit arranged specifically for this program.
Today, we're making this movie to help doctors and nurses and social workers all over the United States. Okay? Is it all right if we take your picture? It is? Oh, good. Thank you so much for helping everyone. You're terrific. And what the doctors want to know is you've been living a long life, and as you've gotten older, your memories started to change, hasn't it? Your memories changed, and so it's not as sharp as it used to be, right? Is there anything you found hard in your later life here? You can't think of anything that's hard? Oh, so it's difficult sometimes to say things? Is that what you said?
Yeah.
Yeah, okay. Well, thank you for sharing that with us. Is there anything you'd like to tell the doctors?
They don't do.
They don't do? They don't do enough for older people? No, they don't, huh? That's right. Sometimes they seem to think just because you're older that you should just let the person go, huh? But you like to be helped. And you need help and support sometimes, right? I was wondering, do you go to church? Mary?
Well, I did.
You did? You have one? You have a church? And do you go to church on Sunday? You do? Mm-hmm. What's the name of your church?
Well, I don't know.
Oh, you don't know the name? Is it Faith Church? I think it's Faith Church.
Yeah.
Yeah. Can you sit back for me, Mary? You're leaning forward. Thank you. Just sit back for me. Sit back a little bit for me, darling. Thank you. And do you have friends at Faith Church? Do you have a friend named Stephen? Mary?
Yeah.
Yeah, you're drifting off somewhere there, huh? You were thinking about something else, weren't you?
Well, Dr. Kanowski wanted us to mention that Mary has Alzheimer's and other dementias, and that she's had dementia for much longer than what is typical, which has affected her speech. And she can understand Mary's speech because she's known her for such a long time. You saw some of that there. Nancy, Peter, your reactions to that exchange, just to start us off with.
I love how much time was spent allowing her to respond, allowing Mary to respond.
Dr. Kanowski was patient and
very patient, giving a lot of time, which is very important, particularly if you've had strokes or that kind of dementia. She treated her with a lot of respect, which is major. The doctor did not get upset or impatient with any of the process. I thought the interaction went well for what Mary was capable of doing, for certain.
And Peter, I noticed she was holding her hand or touching her almost the entire way through that discussion.
Yeah. I think one of the fun things about working as a geriatrician, geriatric psychiatrist, geriatric social worker, is that that's permissible. You know, working with young people, you have to be very careful these days, and sometimes that crosses a boundary. But with an older person, particularly someone like this, that's actually the appropriate thing to do. And as you say, it's a way to establish a connection. That's probably a more powerful connection than the language connection.
More powerful.
Yeah, and I thought that was one of the nice things here. There was a connection between the doctor and the person. And even though she couldn't speak very well, couldn't articulate, they seemed to be interacting.
And I must say, thinking about what you were saying earlier, both of you, about the responses, I'm utterly unqualified to judge this. First of all, I'm not an expert, and secondly, we're watching the picture here. But the patient seemed relaxed in her own way, didn't she? Did it strike you that way, Kathy?
Well, and they're seated. We didn't have a doctor standing and a patient seated, and I think that is also more eye to eye as equals.
It's another example of where the exact meaning is less important than the fact that the doctor was maintaining a conversation. And you are making guesses in that way, and I think you have to realize sometimes what you're guessing is wrong. But right or wrong is not the issue here. It's communicating.
Yeah. Ken, how about the guesses or assumptions or whatever you want to call them, and how that affects the grief experience, which is what this conversation really is all about?
Well, you know, I think the perception of how the patient is doing and how the person with dementia is adjusting, coping, really does impact later on, both on the grief that's experienced during the dementia, during the person's illness, and after. If you think someone's doing well, they seem, you know, and you're saying, well, they may not have their short-term memory, but they're happy, they seem content. I think it's easier to mourn that loss than when they seem agitated, when there's paranoia, when there's all kinds of interactional issues that maybe you didn't have before, or maybe you did. That makes it more complicated. So I think when you look back on the illness experience and say, that was, that wasn't as bad as I thought it would be, or that person, as much as I mourned them, they seemed to be fine, they seemed, I do think it makes it easier to grieve that loss. I do think that's less complicating.
Often people do adapt emotionally over time. It's not that they're not grieving, but they may have a line in the sand, and as Ken said, they'll all of a sudden, that happened 6 months ago, and they've adapted to that. Now there are other challenges to come. So it's up and down, I think, in my experience. I think it is true that after a person dies, the idea that somebody's going to get automatically better doesn't happen, but I don't think we expect that after any death. In fact, we know the idea that you should, quote, get over grief is a misconception no matter what the illness. And people can have that sudden upwelling of emotion 30, 40 years after they've lost a loved one. And so I'm not sure that dementia is that different, and I think we'd want to be careful in not expecting that experience of grief to go away.
Yeah.
Ken?
Well, I guess I would certainly agree with Peter, and I think, one of the old myths about anticipatory grief was, what somebody had once called the hydrostatic view of grief. You had so many tears to to shed, and once you shed those tears, if you shed them ahead of time, you'd have less later on. What we really understand here is that the sense of loss is different. And you know, as you go through the illness, you have various losses, and after the death, you have various losses, and you have various reactions. And one of the losses you may even be mourning is even, which I think a lot of people find it hard to understand, is the loss of a meaningful caregiver role. Right. You know, exactly. Who am I now? I've been doing this for 10 years. I've been doing this for 6 years. Now I'm sort of adrift. You know, this has been my purpose in life. So I'm not surprised at all. I think, you know, at each point, you're mourning different losses.
Chuck.
You know, there's been some study arguing that there is acceptance after a death coupled with denial, and that acceptance is higher in the JAMA article that I'm thinking about and remains higher. I wonder if it's acceptance and maybe perhaps it's acknowledgement. Yeah. That you acknowledge the fact that somebody is dead, but you still can't believe. Yeah. You haven't integrated it.
Kathy.
And with this long disease process, I mean, regardless of the form of the dementia, as it progresses, there are different challenges. At the start, reconciling yourself to the reality of this, the changing of memory. In those middle stages, the difficult behaviors that we talk about, and you get a caregiver who just is getting up to those challenges, and then they move through that paranoia, maybe combative phase, and then there are other challenges. Now, the lack of ability to dress and toilet and becoming more bedfast. So each one of those, a caregiver just sort of gets on top of one set of challenges, and then another set of challenges come. And so it does make a lot of sense that by the time the final death happens, we have some really tired people. And their stamina for
and
grieving.
To that point, you know, again, another very interesting statistic I saw, according to the National Alliance on Caregiving, is that, as you know and as you've discussed, dementia caregiving is especially taxing and difficult in so many different ways. But they found that on average, caregivers spend over 20 hours a week providing assistance with the basic activities of daily living. So that's physically taxing, it's emotionally taxing, and I wonder about this mix of relief and release. Back to the friend I mentioned, very good friend who lost his mother. Those were words he used, but still the family came together, and there seemed a sense of both remembrance and grief, not as if it were wrapped around a tragic or surprising death, but it was a death nonetheless.
I think part of what we have to remember is that our definition of grief is not necessarily feelings of sadness, but any of the reactions, physical, cognitive, behavioral, emotional, spiritual, that follow a death. So, you know, one of the feelings you may have as you experience a death after a long caregiving experience is one of relief. And that may be mixed with a whole series of other kinds of feelings. Maybe guilt about that, you know, maybe a sense of emancipation. There may be a multiplicity of feelings. That's all part of grief. And one of the things that I try to do with clients is to really, because sometimes clients feel bad about that they're quote unquote not grieving more. So I'll always really, you know, kind of reframe that and say, well, that's one of the ways you're experiencing grief. Oh, okay, so it's not a bad thing. It's part of my grief.
And Ken, you also wrote about this notion of disenfranchised grief, which is where people will say, and again, oh, you must be so relieved. You know, it was a terrible thing. We miss your mom, but it's almost a dismissive focus. That make it harder?
Very definitely, because you don't have the social support, and you know, everyone's saying, oh, you know, it's a good thing, it's a blessing, you know, and you know, and again, part of you may feel that way. We're very complex people, and part of you may feel, but this was my mother, this was my spouse, and you know, and again, the caregiving role that was so important to me. Much as I sometimes resented it, it's what I did.
Right. Nancy, you find that a lot. This notion of, oh, it must be such a blessing for you that does it feel a little dismissive at times?
Dismissive, yeah. It's also, though, I mean, it's a paradox, isn't it? You know, yes, I'm relieved, and yet what you said earlier is, and yet wait a second, I was the 100% caregiver. Now what am I going to do with my life?
Yeah.
It's a coexisting reality. You both are going to miss that person and sad about it, but there's also that relief. And I don't think very many people understand that.
Yeah.
And
And then I think there's also this dynamic of you can go back to your life as it was. Well, you can't.
No.
Because you've been absent from that life. That life has changed. You know, the
True.
circles of friends that you've had and you used to go out to dinner with, they're in a different place.
They've
You're in
moved
a different
on,
place.
yeah.
Chuck.
There's a population we haven't talked about yet. What about children and adolescents in families affected by dementia? And I'd like just to remind you that there are 8 to 10 books that I know of written for children about dementia. Often they're grandchildren, but not necessarily. And it's useful to think that there is a small body of literature that could be very helpful to some people in terms of, I'm caring for my grandmother, I'm caring for my mother, but I'm also having to think about the children in my family too, and where can I find support or help from them?
Moving on, healthcare professionals know how challenging it is for families facing medical decisions for a loved one who is unconscious. And they haven't a clue what their loved one would really want. But when a feeding tube was suggested for Deborah Foster's elderly mother who had dementia, Deborah and her sisters disagreed over whether they should even try to speak with their mom about it.
Her capacity to process through something was very limited. And actually, you know, she couldn't put a sentence together at this time, hadn't been able to for quite a while. But she could still express emotion, and she could still, communicate in very limited ways by talking. But my sisters were like, well, there's no need to talk to mother about it because she doesn't know where she is most of the time. You know, she's cognitively, she's just not there. So that's not a decision that she should have any input on, which bothered me because I don't think it was seriously attempted. And it's something that probably I should have done looking back on it. I mean, I'm the oldest sister. I could have walked in and said, well, I'm talking to mother about it anyway, you know, and I didn't do that because I was not in agreement in putting in the feeding tube in the first place. The fact that she had to live those extra months as she did is something that makes the grief harder.
We learned in a recent HFA program on artificial nutrition and hydration that placing a feeding tube in a patient with advanced dementia is ill-advised and could even cause harm. Nancy, let me start with you on this. I mean, we heard Kathy say, I was not in agreement with putting the feeding tube in the first place, and it made the grief harder.
Yes. And that's often the stance in the beginning, that a lot of people within the same family unit will disagree. And so where do you go from here? One person feels with every single cell of her body that mom has never wanted a feeding tube, and everyone else feels, of course she'd want one. You're going to starve her to death if you don't give her one. You know, we know what all the extreme stances are. I'm a firm believer personally in bringing everybody in I know it sounds crazy, but social work, get everyone together, let's figure it out. But including the person who has dementia, because it has never ceased to, once again, to amaze me when the person with dementia can make their opinion very clear when we read those subtle signs. It can happen, it has happened. Does it always? Not necessarily. But I think it's important, at least for everyone in the room, to understand the same information, the same facts. Let's get it all out in the open. Let's get all the fears talked about, all of the emotions.
Ken, does the funeral and remembrance take on more or different significance with a person with dementia?
Well, I think every funeral takes on its own significance and is very individual. And but I think one of the roles of a funeral when a person has had a long time period of dementia, one of the roles of grief counseling is to help families recall the person at prior points in life. So, you know, because often those memories when you're a caregiver, the memories of the person really in the last days, months, really cloud out sometimes the better memories. So I think funerals can be very, very therapeutic there. I just wanted to add one other comment to Peter's and Chuck's too, that, that fundamentally, I think that the great gift of hospice is that, this is really a multidimensional issue of care. And I think hospice can bring in so much, from psychosocial support, to spiritual support, to bereavement support throughout the illness, to medical support, because again, any pharmaceutical, any pain management can be critically important here. And I think the key element is, to the degree that people see that they've been supported in their caregiving, to the degree that people see that the death was better than it might have been. Yeah. We can't always get a good death, but I agree with Chuck, we can often have a better death. Then I think the grieving itself will be less complicated. And again, the funeral has a role in that, because it can bring people together, bring out the support of the community, and maybe rekindle memories that have been long dormant. And I think it's important to recognize that it doesn't end with the funeral, that families can create other rituals during the course of the year.
Memory boxes.
Yeah, memory boxes and things to really bring and remember that person.
Is that a favorite of yours?
Yeah, well, it's a wonderful thing for children especially. And I was going to say, in terms of ritual, I'd add to what Ken said about the child who has always seen Grandpa as an older adult, and maybe always seen him as a demented adult. Yeah. And now, Grandpa was a young person at one time. My God, was even a child at one time.
Kathy, your thoughts?
Well, I think the take-home message here for all of us in dementia caregiving is to prepare families. This is not a sprint, this is a marathon. And really to help people navigate, to give them the tools, the equipment, the knowledge to be effective caregivers, to bring themselves to caregiving. When death comes, and it is sorrowful, even in the presence of a disease that you hope will end soon, when people can walk away feeling they were an effective caregiver, I was a loving daughter, I was a loving husband, that does a lot to enhance a good, healthy grief.
This has been an amazing discussion, and we hope you've shared that sentiment. We've run out of time. I want to thank all of the panelists, Chuck Core, Nancy Pierce, Peter Rabins, Kathy Supiano, and Ken Doka, for sharing your experience, your insight, your candor, your own story, Chuck, which has been most generous of you. Thank you so much, and to your wife, too, all the very best.
Now, here's Ken Doka with some tips and coping strategies.
Thanks, Frank. The first thing is not to panic. There is information and resources available to help you. Make a list of questions for your physician, and don't be bashful about taking notes. Learn about the disease. Sometimes we can think someone is being willfully obstinate or difficult, when really the behaviors are the result of the illness. Take care of yourself. You need not feel guilty about my time. Many caregivers find it helpful to begin by slipping out for a few minutes or even resting while someone else is watching the individual with dementia. As you become more comfortable with other caregivers, you can extend your time away. Remember that you need not do this alone. As you open yourself up to others' help, realize they can play different roles. Some people are more comfortable doing chores, filling in while you relax or run errands. Others may be better at listening. Still others may offer respite, good company for a dinner or a movie when you'd like some time away from home. Formal support can also be helpful. Contact groups like your Alzheimer's Association. They may have local support groups as well as online or phone support. Such support can offer information, allow you to be open about your feelings, validate your concerns, and offer suggestions for coping with the illness. Plan for the future. What will you do if or when caregiving becomes too difficult? Learn about your options from your local Office of Aging, as well as attorneys, clergy, insurance agents, and financial advisors. At the time of death, recognize and allow your grief. Go slowly, give yourself time, and be patient with others who have good intentions, but inadvertently say the wrong thing or try to minimize your grief.
Thanks, Ken.
Before we go, we want to thank our program sponsors and cooperating partners, the Foundation for End-of-Life Care, the National Association of Social Workers, Dignity Memorial Funeral Providers, and the Association for Death Education and Counseling. Also, we thank the Alzheimer's Association for assistance with our research. This has been The Longest Loss, Alzheimer's Disease and Dementia. For the Hospice Foundation of America, I'm Frank Sesno. Thank you for watching.